Tell me about the diagnostic criteria that you as a payer look for to make this all rational.
We don't actually require any diagnostic criteria for insomnia. It's physician attestation. If the physician says the patient has insomnia, that's all it takes.
Wait, here's an insurance company just once saying, we believe you. Docs, you just certify and off we go? Do you come from Mars?
No, that's the truth.
Or is it simply because there's not enough data for you to
Now,
do
if you're
anything
asking
else?
about a sleep study, that's a different animal.
Would you pay for a sleep study based on their attestation?
They're prior authorized, so there are some criteria to pay for a sleep study.
What would that be?
I would have to look up
You'd
the
have to look
medical
it up.
policy. I don't know what it is.
It probably
but-
varies from company to company.
Oh, of
too,
course
right?
it does, yes.
And-
But I think would be the generally accepted criteria to have a sleep study. But just for the diagnosis of insomnia, it's physician attestation. It's done mostly by primary care physicians.
Yeah, as far as sleep studies go, they're generally done if there's a suspicion of sleep apnea.
Okay.
They're generally done if there's concerns about people have these various excessive sleepiness problems, like narcolepsy-related problems, but generally not for insomniacs.
I have the feeling that we're kind of commingling sleep apnea and insomnia. And I guess I think of those as two separate disorders. Not everybody with sleep apnea has insomnia, and by no means everybody with insomnia doesn't have sleep apnea. So, you know, they're two different diagnoses.
Are there ICD-10 codes, and are there different ones for chronic versus primary versus secondary?
Well, there may be, and I think you know, chronic defined as a few months or longer, acute being less than that, primary, secondary. As I said before, though, clinically, those distinctions between primary and secondary aren't all that useful, unfortunately. And even the chronic acute distinction really clinically is not that useful because both can be very consequential.
In the International Classification of Sleep Disorders, the ICD-3 actually did away with those distinctions.
Okay.
It's insomnia
That's
or
it.
not. That's chronic, acute, chronic, but
We're
not
not calling it
these different-
disorder. It's a disorder in and of itself, insomnia disorder.
Are there some neurologic conditions which, of and by themselves, present greater risks of insomnia?
Well,
Yeah, certainly, besides the sort of obvious things, people have back problems and pain and so forth like that. You know, I think that one of the things you're hinting at is certain neurodegenerative disorders, where sleep problems are very common and very prominent. Some of the Parkinson's disease or disorders similar to Parkinson's disease may have sleep problems very early in the course of their, and a lot of emphasis is placed on these non-motor symptoms of Parkinson's disease and related disorders like dementia with Lewy bodies and so forth. Patients with Alzheimer's disease may also develop, in the course of their disease, will develop sleep problems. In fact, it's probably many times the leading reason why families can't take care of patients at home anymore is because they don't sleep at night and the families can't tolerate staying up all night. So yes, it can oftentimes be the leading part. In fact, in my particular practice, I do sleep patients, and I also see lots of patients with these memory disorders and other neurodegenerative disorders. And the two populations sort of mix from time to time.